Good evening, everyone. Welcome to today's Cafe Rangan webinar by Dr. Devyada Hingwala on sellar and parasellar cases. Before starting the webinar, I'll quickly run through the upcoming webinars. We are doing a webinar series in association with the Mayo Clinic on the 4 Sundays of April. This is the schedule for it. Um, Today we have two volunteers from St. G.S. Medical College, Mumbai and KM Hospital. We have Dr. Avni and Dr. Swaksh. Are you there? Can you just say a hi?
Yes, sir.
Yeah, Avni, hi, lovely. Swaksh, are you gonna log? Do you have a separate ID logged in from
No, sir,
separate?
we've logged in from the same device.
Okay, no problem. Fine. Ma'am, the Avni and Swaksh are two volunteers for today's cases. A loud shout out to them for accepting this invite and being brave enough to present this in front of a large international audience. All over to you, ma'am. I would like to introduce ma'am. She's consultant neuroradiologist at Tesla High Tech Imaging Center in Bombay, and she's been a famous neuroradiologist in and around Bombay and also in India with multiple publications to her credit. Ma'am, without any further time, I'll hand over the session to you.
Thank you, Chinmay and Cafe Ranjan. Hi, Avni and Shwaks. We are already delayed and we will quickly launch into the presentation without any further delay. I will just share my screen. Can you see my screen?
No, ma'am, not yet.
Oh, give me 1 second. Okay, now can you see my presentation?
Yes, ma'am, perfect. Can you just make it full screen?
Yeah, I will make it full screen. And before that, I would request Avni and Shwaks, if you have that, there's a marker option, annotate option in Zoom. So when you are also presenting, when I'm asking you to describe the findings, I would appreciate it if you use that annotation option as a marker pointer to point out the findings. Sounds good?
Yes, ma'am.
All right, great. So I'll go to full screen and let's start. So this session is on imaging in sellar and suprasellar pathologies. So Avni and Shwaks are quickly going to tell us briefly about the embryology of the sellar and suprasellar region, because understanding the embryology helps us to understand the pathologies that arise from this region. So, who's going to start with a brief introduction on the embryology?
Ma'am, the pituitary gland develops from two outpouchings, both are ectodermal outpouchings. So you have the adenohypophysis and the neurohypophysis. The neurohypophysis is the posterior pituitary, which develops as a outpouching from the diencephalon downwards, whereas the anterior pituitary, the adenohypophysis, develops as a outpouching from the primitive oral cavity or the stomodeum, and it branches cranially, and that forms the pituitary gland.
Awesome. So that is what is described in this image in the lower panel, as Shwaks described so succinctly. Okay. And okay, so now it's Avni's turn. Since Shwaks described the embryology, Avni will describe the parts of the anatomy. And please use uh, uh, the annotation to mark out the various areas that you are pointing out. Avni?
Yes, ma'am.
Yeah. Please point out the various normal anatomical landmarks on
This
this
is the
mid-sagittal image. Please
this is the
continue.
posterior pituitary, which appears as a T1 bright spot.
Very nice.
This is the normal anterior pituitary, which should be concave upwards.
Okay.
This is the infundibulum.
Very nice.
Anteriorly is this is the optic chiasma.
Okay. Just a little anterior to what you're pointing, but
Yeah, here.
And exactly where you are pointing is what was the annotation that you put before the
Tuber
optic chiasm?
cinereum. Tuber cinereum.
No, it's
Here,
actually
here.
the chiasmatic recess. Okay. And carry on. And then can you show the rest of the parts that I have mentioned? The lamina terminalis.
This one.
Okay. And then we have the hypothalamus
Mammillary
and
bodies. Yeah, these are the.
mammillary body. The one below the mammillary body where your line is there is the interpedunculaire cistern,
Yeah.
and above the mammillary body is the region of the hypothalamus.
Here.
Adjacent to the infundibulum is the infundibular recess, and we have already shown the adenohypophysis in the posterior pituitary right spot. All right, so that mainly covers these anatomical landmarks. And Kamli, can you delete the annotations, please? Great. So, Shwaks, can you tell me the Elster's rule for the normal height of the adenohypophysis?
Ma'am, the Elster's rule it talks about the craniocaudal height of the adenohypophysis seen on a coronal section of the pituitary. So normally 6 mm is for infants and children.
Awesome.
8 mm will be for men and women of post-menopausal age group. 10 mm for reproductive age group females, and 12 mm is the cutoff for pregnant and immediate postpartum females.
Amazing. We are reading from the same textbook, looks like. Very nice. Before we start the cases, I'll just specifically mention when you are talking about differential diagnosis in sellar, suprasellar, parasellar lesions, first we have to identify the sella and the pituitary gland, determine the center of the lesion. Is it excuse me, in the sella, suprasellar, infrasellar, parasellar, or whether it is so what is the location of the lesion and also the characteristics of the lesion, whether it is solid cystic, whether it is calcified, enhancing, are there any abnormal flow voids. For example, Avni, can you describe what pathology you are seeing in this coronal T2 image? and point it out with the annotation for the benefit of the other listeners. Avni, or shall I continue?
Ma'am, I think that the craniocaudal dimension is enlarged in this case of the pituitary.
Okay. Anything else?
The flow void of the left ICA is exaggerated.
Very nice. So it is not the fluid of the left ICA that is exaggerated. This the left ICA fluid is okay. Uh, disappointed. The left ICA fluid is normal. It is the right ICA fluid that is affected. So this was a patient with atherosclerotic changes in the right ICA fluid. Adenohypophysis, I would say, is actually fine. This was a patient with a patient with stroke and with a reduced caliber of the right ICA in the cavernous segment. Okay. So one of you will take this first case. This is a patient with hyperprolactinemia. In pituitary, the good thing about pituitary lesions is that one is that the differentials are quite limited. And the second thing about pituitary lesions is if we pay attention to the clinical history, more often than not, we will have the answer with us. Cases are pretty straightforward. So, Schwartz will take this case. This is a middle-aged man with hyperprolactinemia, and that itself gives you a clue. I just wanted to point out the pathology with the annotation marker.
Ma'am, the image on the on our left shows a T1 coronal image of the through the pituitary, and there is a hypoenhancing. There is a hypointense small nodular region in the right right half of the pituitary.
Yes,
And it is so it's hypointense, and there's no change in the rest of the pituitary contour or the infundibulum or the optic chiasma. And on
excellent.
flare images, it is
This is not
iso-intense.
flare. Both of them are T1 images.
Okay.
The image, this first image that you have just described, is a dynamic post-contrast image. And this is a second image, which is a routine T1 fat saturated thin coronal image. Yeah. So what does this show? Please continue, Shwaksh.
Ma'am, on the routine T1 sequence, there is no, you can't see the adenoma, but on the post-contrast sequence, since the pituitary enhances rapidly, and the early post-contrast dynamic sequences, the microadenoma does not enhance. So that's why
Very
it
nice.
appears hypo-enhancing.
Excellent. So this is the full panel of the dynamic images, which shows that as the contrast is going into the pituitary gland, which actually lacks the blood-brain barrier, we are seeing that the lesion is not enhancing, but the rest of the pituitary is rapidly enhancing, and slowly, and as more and more of the pituitary gland is filling up, even the lesion is filling up with contrast in the later phases of the dynamic post-contrast sequence. So when we are evaluating patients with suspected with hyperprolactinemia and suspected microadenoma, this dynamic post-contrast sequence is very important because most likely it will not be seen. It will very rarely be seen on T1 weighted images. See, now we have seen the dynamic post-contrast sequence. We know this lesion is there here on the right side of the adenohypophysis. Then we'll say, okay, fine, we are seeing some pathology in the right side of the adenohypophysis on T2 weighted images. But without the dynamic images, it would have been impossible to make the diagnosis on the post-contrast images. Hence, like Schwartz very nicely explained, the mechanism and the importance of using the dynamic post-contrast images. So this is another patient, only 51-year-old lady with headache, and she underwent a routine MRI brain. Please describe the findings.
Uh, Ma'am, there is a T1 iso intense lesion will extend in the sellar and suprasellar region, uh, uh, which shows avid contrast enhancement. Ma'am, I think it's a pituitary macroadenoma.
Excellent. So when you're saying it that even isointense lesion, you also have to describe the rest of the lesion, like the size. Obviously, you cannot measure it here, but assuming that you are having films and you are having a ruler to measure the lesion, and also that the superior margin is convex and it is abutting the optic chiasm. All these things are very important to describe in this patient. The diagnosis is obvious. It is an it is a pituitary macroadenoma. What is the cutoff between a micro and a macroadenoma? How do you
Ma'am,
distinguish
10 mm.
10 mm? That's right. So this is a macroadenoma. This is much smaller. It is actually, with a routine complaint like headache, it might be difficult. It might be difficult to find this lesion, but quite likely any of us can miss this pathology. So even when we are reading routine MRI brain scans, it is important to evaluate all parts of the brain, including this very important mid-sagittal image, which will give us a clue to sellar and suprasellar pathologies. Okay, so this is a young male who presented with visual complaints, and this patient underwent perimetry and was diagnosed to have hemianopia.
There's a homogeneously hyperdense lesion causing widening of the sella extending in the suprasellar region, which shows homogeneous contrast enhancement. So, differentials would be pituitary macroadenoma or a meningioma.
Again, it is very important to describe what happens to the parasellar regions. Is it extending to the sellar, paracavernous regions? Is it extending? What is happening to the optic chiasm, the third ventricle? It is extending almost up to the third ventricle,
Yes,
compressing
yes.
the optic chiasm. That explains the patient's symptoms. These patients typically do not have uh, endocrine pathologies, because had they had some endocrine dysfunction, um, this patient would have presented much earlier before this lesion would have enlarged so much. What other differentials you can think of based on this scan? You said meningioma, very good. Pituitary macroadenoma, meningioma.
Another less likely would be craniopharyngioma.
Okay, but craniopharyngiomas generally don't have such homogeneous enhancement,
Yes.
I would say. With such intense enhancement, you know what I would be worried about? I would be worried about missing uh,
Aneurysm.
an aneurysm, a suprasellar, supraclanoid ICA aneurysm. Okay, so that is one thing we have to mention. This is a CT scan. Of course, this is having in this image we are seeing in the coronal reconstruction. It is having a snowman appearance or a figure of eight appearance. It is most likely a macroadenoma, and it did turn out to be a macroadenoma. Here is another patient with a macroadenoma with a large sellar suprasellar lesion with widening of the sella, and more importantly, we are not seeing any normal adenohypophysis parenchyma adjacent to it. So this is a snowman appearance or figure of eight appearance with pituitary macroadenoma. What is the role of doing diffusion and DTI, diffusion weighted imaging and diffusion tensor imaging in these patients?
Ma'am, with DTI imaging, we can have a better understanding of the optic tracts.
Okay. See, basically, optic tracts would be seen, and of course, we are seeing the compression of the optic chiasm. That's what the neurosurgeons are concerned, whether the optic chiasm is compressed and how to protect. This fractional anisotropy maps show how cellular the lesion, the ADC values and the FA values show how cellular the lesion is, and how suckable and crucible the lesion is while doing surgery. So this gives important information. So here is another patient, a middle-aged man, 43-year-old gentleman with sudden onset symptoms. Somebody describe the findings, please.
Ma'am, there is a T1 iso-intense to hyper-intense lesion in the sellar and suprasellar region. There is it's seen compressing the optic chiasma up cranially. On the left side, it is seen extending up to the internal carotid artery and up to the lateral margin of the internal carotid artery. On the right side, it appears to be going till the intercarotid line. On T2 weighted images, there is a fluid level, um, fluid level with hyperintensity lower and hyperintensity above. So in view of
That's
sudden
called dependent T2 hypointensity.
yes, ma'am, dependent T2 hyperintensity. So in view of sudden onset headache, I would suspect a pituitary macroadenoma with secondary apoplexy.
Excellent. Good description. Okay, now here is another patient, a teenager with precocious puberty, hilarchy, menarche, short stature, elevated TSH. She came for an MRI.
Ma'am, in T2 and T1 sagittal images of the brain, there is a T1 and T2 iso-intense lesion in the sellar region. The posterior pituitary bright spot is normal. There doesn't appear to be compression of the optic chiasma, and it is showing avid enhancement on post-contrast sequences. Given the age of the child, and there's no significant widening of the sellar tussica, given the age of the child, I would think of a pituitary macroadenoma or a pituitary hyperplasia.
Pituitary macroadenoma or hyperplasia. So this is a follow-up MRI. TSH also normalized with treatment and follow-up MRI. Can you please describe the findings? Sure.
Ma'am, in the follow-up MRI, the same lesion is not seen. The pituitary appears concave upwards, and there is a normal appearing height of the pituitary. We can't measure it here, but normal appearing height of the pituitary. So in such a case, I would think of pituitary hyperplasia, because pituitary macroadenoma wouldn't regress without treatment unless it was a prolactinoma where you give bromocriptine and there are chances. Otherwise, it wouldn't regress.
But this patient has not received bromocriptine, right? This patient has just received treatment for the hypothyroidism.
Yes, ma'am.
And she also has precocious puberty. And this is TSH normalized and pituitary reduced in size. And this is the USG pelvis. Which is showing multiple
polycystic ovaries.
Multiple follicles in both ovaries. Yeah, multiple cysts in both ovaries. So putting everything together, do you know how we can tie all this together? So like you said very nicely, not all enlarged pituitaries are macroadenoma. It can also be pituitary hyperplasia. And so this patient had precocious puberty with bulky ovaries with multiple follicles, multiple enlarged follicles in both ovaries, plus hypothyroidism. So this is a syndrome called Fanwick-Grumbach syndrome. This is a patient with this presents with hypothyroidism, precocious puberty, and delayed bone age. and also multicystic ovaries. Here is another patient, 2-month-old child with failure to thrive and direct hyperbilirubinemia, delayed development, dysmorphic features, and hearing loss. You can see the yellowish tinge of the skin, and this is the scan MRI. So this is a pituitary lecture, right? So focus on the pituitary.
And the pituitary gland is decreased in size.
I won't say
And
decrease, it's a hypoplastic.
and also the cochlea appears prominent on the left.
Very good. So this patient, and this is a normal 2-month-old patient for comparison to show the size of the adenohypophysis. So there is hypoplasia of the adenohypophysis, and like you said, the cochlea appears cystic bilaterally, not only on the left. That was just partial volume, that you are not seeing the right side. So both the cochlea show cystic dilatation. So what is this condition? This is another congenital condition with jaundice, pancreatic lipomatosis, plastic adenohypophysis, and large cochleae, sensory neural hearing loss, and with the typical faces that this patient is having. Uh, what is this condition? This is Johansson-Bizet syndrome. All right. Coming to the next case.
Ma'am, on T2 and T1 images, there is a uh, the pituitary appears concave upwards. On T2, there is a sellar hypointense lesion within the sellar, and on T1 post contrast, it's non-enhancing.
And where is it located? Yes, it is sellar, but where is it located?
Ma'am,
exactly.
it appears between the anterior pituitary and the posterior pituitary blind spot, which appears normal.
Yes.
And there's no calcific focus, and it's not.
No, we can't say whether it's not calcified. We can't say that it's not calcified, but we assume that it is not. Yeah. There is a focal non-enhancing T2 hypointense lesion between the adenohypophysis and the posterior pituitary bright spot. Right. So diagnosis, please.
Ma'am, a Rathke's cleft cyst.
Awesome. So how will you distinguish this Rathke's cleft cyst from a cystic adenoma? It can also be a cystic adenoma, right? That's the differential.
Ma'am, a Rathke's cleft cyst will not show enhancement even in delayed phase, whereas a cystic adenoma will show delayed enhancement.
May or may not. If it's completely cystic, it may not show enhancement.
Not sure.
So here's the answer. If there is associated endocrine dysfunction and off midline location, it's more likely to be cystic adenoma. Rathke's cleft is typically midline. And the T1 signal of the Rathke's cyst, the T2 signal of the Rathke's cyst also depends on the protein content. So it can be T2 hypointense generally, it can have hyperintense, it can also have an intracystic nodule, which is diagnostic for Rathke's cleft cyst. Okay, so again, this brings us back to the CT that we had first seen. Any sellar, suprasellar pathology that looks hypointense on T2 or even isointense on T2, it is better to err on the side of caution and first rule out an aneurysm. This is a patient with a giant balloon-like aneurysm arising from the supraclanoid ICA, which was picked up on DSA and treated with neurointervention. So here's another patient, an elderly lady with headache and loss of vision.
Ma'am, there's a T2 hyperintense, T2 flare hyperintense, and T1 hyperintense lesion in the sellar and suprasellar region with extension into the which is causing compression on the third ventricle and extending towards the right gangliocapsular region.
That's right. So it is T2 hyperintense on flare as well as T1.
Ma'am, the pituitary is seen separately.
Yes.
So, ma'am, my diagnosis could be a craniopharyngioma.
You have to describe all the lesions, all the parts of all the pathology. So this is a T1 weighted coronal image which shows this lesion. It is hyperintense on T1 and it is not suppressed on the fat saturated images, right? And what is this image? What would you like to say? The diagnosis is correct, but what would you like to say about this lesion?
Ma'am, there's blooming on towards the periphery of the lesion. There's blooming on
Yeah, most
susceptibility.
likely calcification. Yeah, blooming on gradient echo image. So anything that is T1 on that is hyperintense on T1 weighted images could be fat or could be other proteinaceous content. We know it is not fat because it is not suppressed on fat saturated images. Okay, so this is a craniopharyngioma, especially in this age group. It's quite likely. I'm sorry, how do I go to the next slide? Why is it stuck? Is my slide moving? Are we going to the next slide? Okay. So here is another patient. This is a child. So craniopharyngiomas have, the epidemiology can occur in the pediatric population or in the elderly population. So here is another patient with a suprasellar multicystic lesion. Please describe it.
Ma'am, on the T1 post-contrast sagittal and T2 coronal lesions of the pituitary region, there is a multicystic lesion extending from the sellar and suprasellar region, extending into the floor of the third ventricle into the third ventricle. It also has some solid components which show contrast enhancement, which are hypointense on T2 images, and the pituitary is seen separately within the sellar, so it's predominantly a suprasellar lesion. In a child, I would suspect
And
adamantinomatous
also
type of.
there is also a focal.
Yes, ma'am.
tissue
Hypointensity, which could be
hypointense.
calcification.
Yes.
Yes, ma'am. So I would suspect adamantinomatous type of craniopharyngioma in a child.
Also, there is dilatation of the third of the right lateral ventricle. So this is an adamantinomatous craniopharyngioma. Okay, coming to the next case. So we saw two craniopharyngiomas.
Ma'am, on T1 and T2 sagittal and coronal images, there is a hyperintense sellar and suprasellar lesion, which is pushing the optic chiasma upwards, not causing significant widening of the sellar, and there appears to be a fluid level.
With non-dependent T1
Hypo.
hyperintense. Non-dependent T1 hyperintense signal.
Yes.
So that is the fatty component. And so this was thought to be a craniopharyngioma. It was reported as a craniopharyngioma, but on histopathology, there was also an associated Radke's cleft cyst and a craniopharyngioma that had developed with it. So, okay, what about this patient?
Ma'am, on T1, on sagittal coronal images, there is a large T2 hyperintense solid cystic lesion extending from the sellar and suprasellar compartments. It is pushing the extending into the floor of the third ventricle. However, there is no resultant dilatation of the lateral ventricles. On post-contrast sequences, the
There is
solid
some dilatation of that. There is some
okay, ma'am.
Okay.
Ma'am,
Very different
post contrast, the peripheral solid lesions show enhancement, and on perfusion, there is increased uptake in the center, whether like in the pituitary region.
But
So
most of the lesion is hypoperfused, right?
Yes, ma'am.
Most of the lesion. Okay. Did you mention about the adenohypophysis?
And the adenohypophysis appears normal.
It is seen separately from the lesion.
Yes, ma'am.
Okay.
So
What
I
are you
would
thinking?
suspect a suprasellar mass. It could be a craniopharyngioma. It could be a chiasmatic glioma, or an astrocytoma.
Or other differentials? This is a child. Even though not mentioned, you can make out from the morphology. Germinoma. It could be a germinoma. And of course, this was an opticochiasmatic glioma. And we have to see any suprasellar mass. If you're seeing the adenohypophysis separately, it is not a pituitary adenoma. So this is the first thing we have to rule out, just to stress upon that part. Okay, here is an adult lady with NF1, and we are seeing scans over time. Okay, I'm sorry, I did show the answer, but please describe the findings.
Ma'am, actual sequences of T1 T1 pre and post contrast and T2 sequences show solid cystic lesion in the predominantly in the left temporal lobe. The cystic component is T2 hyperintense, T1 hyperintense, and the solid component is hyperintense on T1 and T2. The similar morphology lesion is seen in the sellar and suprasellar region as well, and there is significant T2 hyperintensity in the left temporal cortical and subcortical region system of edema. The optic nerves appear to be tortuous. Bilateral optic nerves appear to be tortuous. And there's involvement of the right orbital apex as well, causing papilledema on that side with flattening of the posterior sclera. So I would suspect a chiasmatic glioma.
That's right. So this was the diagnosis. And so here is this patient that shows follow-up over time about how the lesion progressed, and especially the solid component of the lesion progressed over time. Okay, next patient.
Ma'am, in the suprasellar region, there is a heterogeneous lesion. The pituitary is seen separately from the lesion. It is extending into the floor of the third ventricle with dilatation of the left more than the right lateral ventricle. On susceptibility, there is peripheral hype. There's susceptibility on the SWI images peripherally. And on T1 axial non-fat images, there is hyperintensity as well. So I would suspect a suprasellar mass which has hemorrhage within it.
And it shows restricted diffusion in the center of the tissue.
Yes.
So it is not a craniopharyngiomas, they generally do not hemorrhage. So what can it be? Suprasellar mass with hemorrhage? So it can be we diagnosed it as a pilocytic astrocytoma, but it turned out to be a pylomyxoid astrocytomas. Just wanted to mention that these lesions can show hemorrhage and restricted diffusion. And this was BRAF mutation positive patient. Okay, I won't even give the history for this case. Somebody just describe the findings and make the diagnosis, please.
Ma'am, there's a T2 iso-2 hypointense lesion involving the region of the tuber cinereum. The pituitary gland is seen separately from the lesion. Uh, my diagnosis would be most likely a Hamar tumor.
Yes, and it can also be a glioma, but you are right, this is a hammer. Okay, coming to the next patient. A middle-aged gentleman with headache came for a routine CT brain, and when we saw some findings on CT brain, we did an MRI.
Ma'am, on CT, there is on the bone window of the cervical CT, there is widening of the sellar turcica.
That's
on
nice.
the MR sequences, there is a T2 iso-intense and T1 iso-intense lesion in the sellar. In the sellar, it is not extending into the suprasellar space. The infundibular stalk and the optic chiasma appear normal. There doesn't appear to be any erosion of the underlying sellar. And on post-contrast sequences, there is enhancement at the anterior-inferior aspect of the lesion, predominantly. So my differentials would be a pituitary macroadenoma or a meningioma.
Excellent. So we are seeing that the adenohypophysis is enhancing separately from the lesion. So this is not a macroadenoma. This is a meningioma. Going to the next case. So here is another patient.
And this is the T1 post-contrast sagittal section, which shows a sellar and suprasellar avidly enhancing lesion, which is seen extending along the dura of the planum sphenoidale. So my first differential would be a meningioma because of the dural tail.
And this was a meningioma. I don't think there are any differentials also for this. Next case.
And there's a lesion in the region of the suprasellar cistern with peripheral calcification and what looks like fat attenuation uh, within the lesion. There are also few linear along the sulci. There are few linear hypodensities, which also are of fat attenuation. So this would be a dermoid with,
A suprasellar dermoid with rupture. And describe the MRI findings, please. The same case.
yes,
The
ma'am,
MRI
with
of
a
the same
T1
case.
heterogeneously enhancing lesion, which
No,
shows
this is pre-contrast.
heterogeneously hyperintense lesion, which shows suppression on the fat cell sequence with areas of blooming, and there are similar hyperintensities along the sulci, which would represent the rupture.
So this was a ruptured dermoid. Uh, 52-year-old lady came for a routine MRI brain with complaints of headache.
Ma'am, there is T1 hyperintensity in the right parasellar region. Um, the posterior pituitary bright spot and the adenohypophysis appears normal.
Diagnosis, please.
Ma'am, I'm not sure.
Lipoma. It could be a lipoma or a dermoid. This is an incidentally seen finding. So here is a child who came for MRI, and these findings were seen on the. This patient came for an MRI brain for headache. I'm sorry.
And there's a T2 hyperintense and T1 post contrast non enhancing lesion in the hypointense lesion in the sellar and suprasellar region. So the diagnosis would be a arachnoid cyst. Like,
Excellent. And this is the last case. No, I think there's one more. Sorry, last case. So this is a 36-year-old man with right-sided facial pain since a year, as well as diplopia. I'm looking to the right side, progressively decreasing, basically progressive visual complaints. Diplopia, decreased vision, drooping of the eyelid on the right side.
Ma'am, there is a homogeneously hyperintense T1 homogeneously hyperintense lesion seen in the right mesial temporal lobe and parasellar region, which has decreased perfusion, decreased uptake on perfusion, and it is heterogeneously hyperintense on T2 sequences.
Hypointensive, that's right.
Yes, ma'am.
Differentials. Okay, one more thing you have to describe anytime you describe this parasellar or cavernous lesions is the caliber of the ICA flow void. So remember to mention that.
Yes, ma'am. not sure about the diagnosis, ma'am.
Okay, just give the differential, 7 You can get the diagnosis only on histopathology. So this is a right paracavernous lesion with T2 hypointense signal and intense post-contrast enhancement.
Ma'am, intense post-contrast enhancement would indicate a meningioma.
Meningioma is one differential, excellent. But we are seeing the perfusion images. How do you think meningioma on perfusion? They would show, they would be avidly hyperperfused. So this is not a meningioma. Other cavernous paracavernous lesions.
Ma'am, it could be a trichoma and a schwannoma since it's
Schwannoma.
hypointense centrally.
Yes, it can be a schwannoma. It could be some inflammatory pathology, like inflammatory pseudotumor, Tolosa. And this turned out to be Rosai-Dorfman disease. All right, and coming to the last case, here is this patient with short stature. 12-year-old man with 12-year-old boy with short stature for MRI. Please describe the findings and give the diagnosis.
Ma'am, the posterior pituitary bright spot is seen cranial to its normal location.
Yes.
The corpus callosum is not well visualized.
Corpus callosum is visualized well. Wait, I'll show you with the marker. This is a corpus callosum. That's well depicted. The corpus callosum, the septum pellucidum are well. But yes, when you are seeing any pathology of any abnormal location of the posterior pituitary bright spot, you have to look at all these findings. That's correct. Okay, so posterior pituitary is not in a proper location. What are the other findings that you are seeing?
Ma'am, the pituitary infundibulum is not seen dipping into the sellar region. So,
yes, very thin and attenuated. Yeah.
Yes, ma'am. And since the posterior pituitary develops as a downgrowth from the diencephalon, with the absence of the pituitary stalk and the pituitary posterior pituitary bright spot being high up, I would suspect an ectopic pituitary.
Yes. And there's one more finding. The adenohypophysis, how would you describe it? It's small, right?
Ma'am, appears hypoplastic.
Okay. So, in addition to these findings, like you mentioned, you have to look at the corpus callosum. What are the other associated findings? So, like septo-optic dysplasia, look at the septum pellucidum, the optic nerves, corpus callosum, and also single central incisor on clinical examination. Okay, fine, sir. This is the last case. This is a patient with hypogonadotropic hypogonadism who came for MRI. What are the findings?
Ma'am, on the sagittal image, the posterior pituitary white spot is normal. The infundibulum and the adenohypophysis height appears normal. But in the cis sequence, coronal cis sequence, there is absence of the olfactory bulbs within the olfactory recess within the CSF space.
So what is that?
So in all cases of hypogonadism, I would suspect Kalman syndrome with olfactory agenesis.
Yes, absolutely right. So To conclude this presentation, we have to localize the tumor, look at the clinical profile, which gives us a lot of clues for the diagnosis. The dynamic sequence is very important in evaluating patients with microadenoma or endocrine dysfunction. And suprasellar masses, uh, in all patients with suprasellar masses, we need to try to look if the adenohypophysis is seen separately from the lesion. Somebody has asked a question. I'll just quickly go through this question. If there are large pituitary, if there's a large pituitary adenoma, may not be there may I mean it is possible, quite possible that there is not so much hormonal dysfunction, endocrine dysfunction. That is why it has developed so slowly over time. That is why it has had a chance to grow so big. If the patient had obvious overt endocrine dysfunction, the lesion would have been picked up much earlier. Fat does show blooming on SWI. I mean, just read up the physics of it. I don't recollect the exact explanation, but it is to be with the phase of the fat. It does show blooming on SWI. Again, the embryology is that the Rathke's cleft cyst is is arising from the Rathke's pouch, and the craniopharyngioma is also arising from the Rathke's pouch. That is why. Okay, I hope that answers the question. Anyone has any more questions? Do Avni and do both the volunteers have any question?
Good evening, ma'am. Thank you so much for that wonderful session. There are a couple of questions, and yeah, I think you have taken all of them. Yes, thank you so much for patiently answering those questions and a wonderful Viva session, like a Viva voice session with Swaksh and Avni. A loud shout out to both of these guys from Sri GS Medical College in Bombay.
They have aced all the cases, I must say.
Yeah.
Good job.
So, yeah, I think they're exam ready already.
Absolutely.
Yes, ma'am. Thank you so much for sharing your knowledge on this platform and giving your time on the Saturday evening.
Thank you for
It was
having me
lovely
here.
to
Have a
have you
nice
again
weekend.
as always, and hope to see you again in future on this platform.
I
Thank you.
look forward to. Have a nice weekend,
Thank
everybody.
you, ma'am.
Good
To
night.
the audience, good night, ma'am. Do join us tomorrow for our international webinar. We are starting the Mayo Clinic series on all 4 Sundays of April, beginning tomorrow. Tomorrow is 7 p.m. And see you there.